Good afternoon, everyone, and thank you for joining us for today's presentation addressing National Pharmacare in the age of COVID-19 and beyond. This is our fifth and final webinar in our series making up our 16th annual TELUS Health Conference. We hope you've enjoyed and benefited from these virtual sessions thus far. It's been our pleasure delivering them, and we wish you another insightful presentation today. And with over 1,000 registrations for this presentation alone, the series is truly ending on a high note. For those of you who are unfamiliar, I'm Jason Kennedy. I'm a Director of Health Business Consulting here at TELUS Health. And with past presentations in this series, I will be your MC for today's session. Given it's our last session, I just wanted to share that I've really enjoyed emceeing these webinars. It's been great to follow along the awesome content, the presentations, and the speakers. But in fairness, I really think I'm starting to hit my stride and getting comfortable talking to a blank screen. And to that one person who provided feedback to say that they liked my jokes from earlier sessions, thank you. Your feedback has been invaluable. I'm just kidding. No one said I was funny. So anyway, let's get started with our webinar. This virtual conference has been made possible today thanks to our supporters and our insurer steering committee partners, Canada Life, Equitable Life, La Capitale, Sun Life Financial, and Union V Insurance. Before we begin, we'd like to share some important tips on how to optimize your webinar experience. For better sound quality, we recommend that you dial in with your phone to listen to your presentation and turn the volume off on your computer. Your audio should already be muted by default. Feel free to network with other webinar participants. To do so, please follow along the instructions currently shared on the screen. And there are two ways to ask questions during the presentation. One is into the chat at any time directed toward the presenters, and the other is during the Q&A session. And for that, we will be sharing instructions later on in the presentation. If you happen to experience technical difficulties on the WebEx, email us at telushealth@telus.com. or send a message to my colleague, Susie Kim, via the chat function. We'll do our best to address these questions. Today's webinar, as with past webinars, are being recorded and it will be made available on the TELUS Health Benefits Hub in a week's time. To be notified, if you haven't already, please subscribe to the mailing list there. And this is where you'll want to go for those past sessions, including some of those lame attempts at humor I referenced earlier. For those who are Twitter enthusiasts in the audience, please use the hashtag #HealthBenefitsTrends to chime in on our conversation. And as I've noted previously, we're always eager to improve. So at the end of this webinar, you'll be invited to fill out a 3-minute survey. Please help us get better at this, and whether it's content, style, future topics, all are fair game. So thank you for that in advance. And CE credits, the participant list for this webinar will be submitted, rather the attendee list will be submitted with webinar material for CE credits. So please allow us a couple of weeks to get back to you. And without further ado, I'd like to introduce today's speakers, the people you're here to see, Dr. Bob Bell and Michelle McLean. Dr. Bob Bell was the Deputy Minister of Health and Long-Term Care from 2014 to 2018, and prior to joining Hill & Knowlton, he served as President and Chief Executive Officer of the University Health Network, Chief Operating Officer at Princess Margaret Hospital, and Chair of both Cancer Care Ontario's Clinical Council and the Cancer Quality Council of Ontario. Dr. Bell is a Fellow of the Royal College of Physicians and Surgeons of Canada, the American College of Surgeons, and Honorary Fellow of the Royal College of Surgeons in Edinburgh. As an executive recognized, as an internationally recognized orthopedic surgeon, health system executive, clinical scientist, and educator, Dr. Bell has more than 40 years of healthcare experience. And Michelle McLean, she's a Senior Vice President and National Health and Wellness Lead for Hill & Knowlton Strategies Canada. Michelle has over 15 years of experience in public affairs and strategic communications, specializing in the health sector, serving both the corporate and nonprofit sectors. Michelle previously served as Vice President of Public Affairs at the Mental Health Commission of Canada, where she managed several national large-scale projects, including the launch of Canada's first national mental health strategy. Before her public affairs career, Michelle practiced as a corporate litigation lawyer. Michelle has twice been named as a top 100 lobbyist in Ottawa. Dr. Bell and Michelle, over to you.
Thank you very much, Jason. Good afternoon, everyone. And thank you to the organizers and sponsors of today's session for the invitation to join you this afternoon. I speak on behalf of Dr. Bell and myself. We're very pleased to be here and looking forward to the discussion. Next slide, Melissa. I'll just quickly touch on the items that we're going to discuss today. We're going to try and situate the COVID-19 pandemic for you by way of context before getting into the political landscape and the policy implications of the pandemic, and then move on to talk about Pharmacare and where it stands now. We'll also review some of those competing policy issues that will impact the path for Pharmacare, and then discuss what comes next. So to cue up the policy and political discussion, I will pass it over to Dr. Bell, who will give us some great insights. Over to you, Bob.
Thanks very much, Michelle. If we could have the next slide. And I must say, Jason Kennedy, that you are actually one of the funniest MCs that I've had the opportunity to work with virtually. So thank you, Jason, for being here today. You know, I think we're all concerned about how Canada is doing in coping with this the spiral threat with this pandemic. And I think it's fair to say that Canada has really worked quite well in combating the virus through a variety of means, mostly through social interventions, through the distancing, social distancing, through the elimination of non-essential activities. And as you can see from this slide, we certainly haven't experienced the numbers of new cases nor the mortality experience that other countries have reported in fighting this virus. However, like everything in Canada, the experience of COVID-19 depends on where you live within our country. Next slide, please. And I think it's fair to say that we've had different pandemic experiences from coast to coast. The Atlantic provinces have not experienced as many new cases or have not experienced the same degree of mortality as our central provinces have. Certainly the pandemic has hit hardest in Quebec and in Ontario. Alberta's had about 5,000 cases to date. And in British Columbia, which began the COVID-19 experience in Canada, they've certainly been very effective in ensuring their citizens have been protected from this virus. If we look at why various provinces, just go back one slide still. If we look at why various provinces have had the experiences that they've had with the virus, it's perhaps a matter in many ways of luck, partly in terms of when their school breaks were scheduled. So Quebec was unfortunate in having the earliest spring break. We all recognize spring breaks when parents take their school-aged children out of school and will frequently go to Quebec or perhaps go to Florida or go to New York or go to France, where Quebecers frequently vacation during March break. And Quebec's March break was scheduled at the end of February, before COVID was really recognized for the threat that it's become. Ontario's spring break was scheduled a couple of weeks later, and Ontarians, when they left, recognized the fact that they were going to need to socially isolate themselves from neighbors when they returned. Whereas British Columbia's March break followed Ontario's, and by that time, the British Columbia Chief Medical Officer of Health, Dr. Bonnie Kennedy, was advising people that they should stay home or certainly isolate themselves on return. So the experience that people had, the number of travel-related cases seems to have varied by the timing of March breaks across the country. Next slide, please. If we look at the two provinces that have had the biggest problem with COVID-19, Ontario and Quebec, until recently, Quebec was having the greatest number of cases reported on a daily basis. This has changed just recently over the last week. Quebec has actually had fewer cases in Ontario. Ontario probably peaked with the virus sometime around the 24th of April. Quebec a little bit later, the end of April, start of May, but both provinces are now on the downward limb of the epidemic curve. Next slide, please. Probably one of the most important aspects that the international healthcare has faced with this virus is the risk of health systems being overwhelmed. And across the country, there were tremendous efforts made to prepare health systems, prepare hospitals for the response to COVID-19. Ontario, for example, went from about 90 critical care ventilated beds per 100,000 people to over 200 in the space of about 2 weeks in preparing for the virus. Elective surgical activity, as you know, across the country, diagnostic procedures have been stopped in our hospital sector. And fortunately, Canada has not had the same experience that Northern Italy or New York City had encountered in their health systems, their hospitals, their emergency departments, being overwhelmed by numbers of new patients. As you can see from this graph demonstrating the occupancy of both hospitals and the smaller yellow graph bars below the top graph, the experience of the number of people on ventilators in Ontario critical care. The peak that was experienced in new cases in the third week in April can be reflected by a peak occurring about 2 weeks later in hospitalized patients, and certainly now Ontario and other parts of the country are on the downward limb of the epidemic curve in terms of hospital occupancy and critical care occupancy. Next slide, please. While our hospital sector has been well protected from the COVID-19 virus and has avoided that overwhelming feature seen elsewhere, certainly the real impact of COVID-19 across the country, and especially in Ontario and Quebec, has come in our long-term care sector. In our areas where congregate cases of people living together, often more than one to a room, often people who are vulnerable because of age and intercurrent illness, certainly the COVID-19 story in central Canada has been one of outbreaks in long-term care, and certainly mortality in long-term care has been disturbing. Next slide, please. Approximately 60% of cases have been in long-term care, but 80% of mortality has occurred in our central provinces. And it's easy to see why that's happened. When we look at the long-term care experience in Ontario, we have about 78,000 Ontarians living in long-term care. And of those, about 30,000 of the 78,000 people actually share a bedroom. 2 to 4 people in a room. Sharing bathrooms is commonplace. We also, until the government changed the ability of staff to work across different long-term care settings, we frequently see staff working casual or part-time work and going across more than one long-term care nursing home to achieve full-time work. And of course, potential for spreading the virus in this regard is easy to see. So certainly, as we think forward to the impact that COVID-19 has had on Pharmacare and other issues in the healthcare sector, one of the things that has certainly been highlighted by COVID is the need to think about what our long-term care system is going to be like in the future, and the need to think about reform in this sector is becoming perhaps a competing priority with Pharmacare going forward, amongst many competing priorities. Next slide, please. So I'll hand it back to Michelle to think through the political landscape and some of the policy implications of COVID-19 and impacts on Pharmacare.
Great. Thanks, Bob. I think it's fair to say that it's hard to overstate how COVID-19 has interrupted life across the world, but it's true for politics too. So if we go to the next slide, I'd like to touch on how it's changed things across the country, certainly in Ottawa, politically, from a policy point of view, and from an issues management point of view. So let's start with the political. Obviously, these are unprecedented times and government is not operating in normal fashion. You will have seen that the House of Commons is primarily meeting virtually, does have infrequent in-person sitting days with a much reduced House. But it's fair to say that Parliament has never operated in this way before. We have committees who are also sitting virtually, but again, their meetings are restricted to hearing from witnesses about the pandemic. They are not exploring other topics. This is a government that is exclusively focused on the crisis response and increasingly turning to recovery planning. From a political point of view, you will have seen from the beginning of the pandemic a real focus on how the government was going to respond. The Prime Minister spoke to the nation from the front steps of his residence every day, and that practice continues. And what that meant, of course, was that there was a lower role, a lower visibility for the opposition parties. They've not had the media coverage, and they frankly have not had the opportunity through the House of Commons sittings to really play a demonstrable role in the nation's response to the crisis. When the government has tabled legislation, there have been amendments, and that has been helpful, I think, from the opposition parties. But obviously, they are adjusting themselves to a completely new role and really trying to understand the boundaries of how far can they challenge the government through a crisis period without shaking the confidence of the parties. From a policy point of view, all non-COVID related legislation is on pause. And so that's too numerous to review today, but things like the assisted dying legislation, which was to come forward, of course, that's on pause. But so are some of the signature policy initiatives that the government promised through the last election, like Pharmacare, and we'll get into where it stands now, but other things like efforts around Indigenous reconciliation, safe drinking water for First Nation communities, environmental policies. We've seen the wireless spectrum auction pushed to next summer. So essentially, in Ottawa, if it's not COVID related, it's very difficult for government to engage. They simply are at max capacity dealing with their crisis response and in turn starting to plan for recovery. The other thing that you will have seen, I'm sure, through the news is the importance and the visibility of the collaboration between the federal and provincial and territorial governments. It's unprecedented, again, to have weekly teleconferences between the premiers and the prime minister, all necessary, of course, but it harkens a new era, and I think we'll see that closer collaboration between the levels of government going forward. The other thing to note, of course, are the unprecedented deficits that are projected. The government is aware of them, the opposition is aware of them. They're starting really to get their heads around how they'll deal with them. But even today, when the Prime Minister was pressed about when he would be providing an economic update to the country, he still isn't able to commit to a date because there is just so much economic fallout that they have to get their heads around. From an issues management point of view, certainly the pandemic response in the economy is at the top of mind for government, but also, of course, managing international relations, in particular with the United States and China, where we have real supply chain issues that have to be managed. So there has been a lot of effort put into ensuring that our relationships with foreign governments go forward in a positive way so that none of our domestic issues are impacted. And finally, as I said, government now is really starting to move to tackle some of the recovery issues that they understood would come and need to be planning for. So next slide. So where is Pharmacare now? I thought it might be helpful to refresh our memories about where we were just a few months ago. And so on the next slide, I have outlined just at a top level some public opinion polling that was done at the beginning of the year, obviously pre-COVID. And what you'll see from some of these stats is that Canadians agreed that Pharmacare was an important priority, that affordability and fairness was at the top of their concerns and considerations. Mm-hmm. But if you see that stat, 83% of Canadians had some form of drug insurance So that's an important thing for us to keep in mind, and certainly it will be for governments going forward. So I think we can understand, and you'll recall there was general support for Pharmacare, but the real question is, what would the numbers look like now if we went back to the public to poll them on the importance of Pharmacare and, frankly, some of the trade-offs that the country is going to have to make? So with that, I'm going to pass it back to Bob to talk more about where we are before COVID emerged on the politics of Pharmacare.
Thanks, Michelle. You know, when we look at the interest in Pharmacare across the country, it certainly needs to be thought of as an issue of drug affordability. And we recognize that one of the chief arguments made for Pharmacare is that if we're able to purchase drugs together, if regulatory changes are made to decrease the international pricing of drugs in Canada, that we might be able to reduce the cost of drugs to Canadians overall. And certainly the work of the Patent Medicine Pricing Review Board, PMPRB, the regulatory changes that were proposed for this regulatory body were positioned as a foundational element for implementation of a Pharmacare plan. If we are to afford Pharmacare, it's necessary that the Canadian characteristic of paying more than most countries for patented medicines must be reduced. The other thing is the issue of model. You know, there have been two broad goalposts described: a single-payer system where the government pays the first dollar and all dollars with respect to the cost of drugs, or the other potential extreme of a fill-in-the-gap approach, where we look at the people, the 10 to 15 to maybe as far as 20% of people who either have no drug insurance or inadequate drug insurance, and look at ensuring that all Canadians have access to pharmaceuticals, but we don't think of the government as a single payer. Certainly, these two descriptions, single payer, fill in the gap, serve as the two extremes of the Pharmacare discussion. One of the other things that's become obvious is that the price of drugs and the availability of drugs has been improved by pan-Canadian organizations, such as the Pan-Canadian Pharmaceutical Alliance. And the thought of the PCPA as a pan-Canadian agency that's improved our drug policies in this country, expanding to include other agencies, PMPRB, CADIF, which provides evidence on cost effectiveness of agents and what drugs should be approved on an evidentiary basis, some of Health Canada's work on providing notice of compliance for medications, and perhaps some of the work researchers are undertaking with support of CIHR, that these functions would all be included in a single drug agency. And if we're to move forward with a pan-Canadian approach to Pharmacare, certainly a single drug agency looking at evidentiary issues, looking at approval issues, looking at negotiations being done on a pan-Canadian basis under one agency, this common drug agency approach would be important to starting a Pharmacare discussion. Provincial negotiations have been recognized as essential for the federal government in influencing the adoption of Pharmacare across the country. Different provinces have different approaches to how insurance is provided on a governmental basis for their citizens. Certainly some provinces, Quebec and British Columbia probably at the head of this list, feel that Pharmacare is already available for their citizens in Quebec, either through workplace insurance or mandatory insurance supported for low-income groups by the government. Quebecers feel that Pharmacare is already present for all citizens, and there's no need for the federal government to influence further insurance for Quebecers. If we look at the political context across the across the country, certainly prior to COVID-19. The foremost NDP demand of the government was to introduce Pharmacare, and certainly we saw the NDP seeking to implement the government's position with its first private members bill, insisting that first payer Pharmacare for all Canadians be introduced as policy. I'm going to pass back to Michelle now to talk about the leadership impacts of Pharmacare at this point and how this impacts the life of Parliament. Michelle, back to you.
Great. Thanks, Bob. So if we can advance slide, let's talk about how things have changed and where do we find ourselves now in terms of the politics of Pharmacare. So Bob talked about drug affordability and how important that was. The federal government had really staked its credibility on moving forward with lower drug prices. It's a pledge they've made in the lead up to the last election, through the election, and post-election period. And they were going to achieve those drug price reductions through changes to the Patent Medicine Price Review Board regulations. Some of you may be familiar with that process that's been underway over the past 2.5 years. Those changes were set to come into effect on July 1st of this year, but they too have been delayed and pushed out till January 1st of 2021. The reason that's important is so much of the affordability question in government's mind was going to be answered through those PMPRB changes. And it's not just that the implementation has been delayed. The government is still consulting with stakeholders on the guidelines that will guide some of those changes. And so, in fact, next week they will publish an updated guidelines, and the 30-day consultation period will begin. So there's still considerable work to do before those changes will take effect. The model matters. In my view, this is probably the single biggest impact of COVID on the path to Pharmacare for Canada. As Bob rightly said, there was a disagreement, certainly in the public, I would think even with stakeholders, but even within the Liberal Party, frankly, on which model Canada should adopt. And there was equal passion for fill the gap model as there was for that universal single payer. Well, given the deficits that Canada is expected to see, I think it's intuitively the case, but certainly we're hearing as well in Ottawa that fill the gap camp now feels it has an edge, given so many other areas that will require increased spending in health. It's a real question whether the government still has the fiscal maneuverability to go to a universal single payer system. In terms of are things moving? No, they're not. Things in Ottawa that are non-COVID related are stalled. We don't see any signs that there is work underway on establishing the Canadian Drug Agency. And of course, that agency was to have the lead on creating the essential medicines list and the strategy for drugs for rare diseases. So I think it's fair to assume that those policy initiatives, like so many others, are really on pause until the country feels it can move forward on anything that is not related to COVID-19. There are, of course, no provincial negotiations scheduled on Pharmacare. The provinces and the federal government undoubtedly will be talking about health transfers and probably have been through the course of the pandemic. That is going to be a huge source of negotiation between the levels of government, but Pharmacare has fallen way down the list in terms of priorities for the premiers and certainly for the federal government. They're really looking to meet the immediate needs of the current healthcare system in crisis. As Bob alluded to, for many years, NDP has made a universal single-payer Pharmacare system a top policy priority. But as we've seen the crisis unfold and the devastating impact in the long-term care sector, that issue has supplanted Pharmacare as their top policy priority. And that's not to say if you ask the party, they'd say that they're moving away from support for Pharmacare. It's just the political attention that will be paid to long-term care means that it is now a top issue for the party. And of course, racial inequality has always been a policy priority for the NDP, but in today's world, we can expect only that priority to climb. So it's a real question on how hard the opposition parties will be pushing for a single-payer universal Pharmacare program. Of course, the other opposition parties are still looking for leaders. Both the Conservatives and the Green Party have leadership races underway, and of course, that's a distraction from driving policy as well. And in terms of the Parliament, as we talked about at the beginning, if it's not COVID related, it's very difficult to move anything forward. So there are no discussions happening on Pharmacare within Parliament, and as far as we can tell, within the parties as well. So I think we can expect for the moment that Pharmacare is in a stalled position, certainly at the federal level. But on the next slide, I'll hand it back to Bob to talk a little bit about the provincial perspective.
So, as mentioned earlier, many provinces already have significant Pharmacare programs in place, and they differ substantially. For example, in Ontario, the seniors program is extremely generous and is not income-based. There's no review of income. All seniors are treated the same, whereas in British Columbia, seniors plans are actually income-based, and people with better incomes are expected to contribute more. Of course, the model in Quebec with either workplace insurance or mandatory insurance for all Quebecers, supported for low-income Quebecers by government funds, is a totally different model than exists elsewhere in the country. So some provinces feel that Pharmacare is by far not their top priority. And some provinces feel that they would simply want the funding that will go to other provinces in order to pay for the approach to Pharmacare that they've already have in place. The one place that provinces probably would agree that Pharmacare could be helpful is the Pan-Canadian Drug Agency approach. Certainly all provinces recognize the Pan-Canadian pharmaceutical approach has improved their ability to negotiate with international pharmaceutical companies, and probably other aspects related to a Pan-Canadian approach could have benefit. The essential medications list is something that would solve the problem of the 10 to 15% of Canadians who don't have access to drugs or inadequate payment for the pharmaceuticals they need. Probably an essential medicines list would be something to get provinces to agree on. And of course, a pan-Canadian strategy for rare diseases, both the testing for rare diseases and the expensive, often life-saving pharmaceuticals that can address rare diseases with innovative solutions are something that all Canadians recognize are necessary for us to achieve a strategy that makes these drugs available, but also something that represents risks for provincial healthcare budgets. So the concept of finding an essential medications list, developing a rare disease strategy for the country, and putting a Canadian Drug Agency into effect are probably three elements where federal government would lead in provincial negotiations to achieve a start to pan-Canadian Pharmacare. The provinces want the ability to opt in or opt out of a national Pharmacare plan with full compensation if they don't enter the plan. But of course, the federal government has the time-honored option of offering something that can be signed up to or not. So rather than having multilateral negotiations to agree on Pharmacare, an effective method for the federal government in coming to a final solution on the Canada Health Transfer, for example, in the last round of FPT negotiations, was to offer extra funding for mental health and for home care expenditures, and simply saying to the provinces, take it or leave it, sign up or not. And that was successful in getting all provinces on board within a matter of months. But that Canada Health Transfer remains the key priority for provinces, wanting the freedom to choose where that federal funding would be introduced to their health systems. Most provinces think that Pharmacare may not be at the top of their list of priorities. Hospital funding, long-term care capacity, mental health capacity could all be considered as above Pharmacare in the list of provincial priorities. And this will certainly result in long discussions between the provinces, territories, and the federal governments, should the federal government decide to push forward with pan-Canadian Pharmacare. Next slide, please. And the competing policy issues are simply growing day by day as a result of COVID-19. Next slide. I think Michelle and I will both comment on this, but certainly the experience of COVID-19 with congregate care of seniors in retirement homes and nursing homes, long-term care across the country, I think Canadians have generally been surprised by the way that COVID-19 has affected our long-term care sector and has brought to light the fact that so many of our seniors with vulnerabilities, with intercurrent diseases, live in circumstances that simply don't feel right in this day and age. People sharing rooms with four other residents, people sharing bathrooms, people having workers who work in multiple long-term care facilities, bringing the risk of viruses with them, long-term care that doesn't have access to appropriate personal protective equipment, long-term care that oftentimes doesn't have appropriate staffing, especially when staff members have become ill like residents have. These are all features that have focused Canadian attention on long-term care. And certainly the experience in Ontario when members of the military were called in to help with 5 long-term care homes which had been unable to achieve staffing. The so-called military report that resulted from their experiences in long-term care suggesting that seniors were being neglected in these very stressed facilities has captured the attention of Canadians. And I think that long-term care has come to the top of our priority list in terms of reforms for the future. Certainly our public health responsiveness, our ability to trace and track people who are diagnosed with COVID-19, the recognition that this virus may be here for the next 2 years. There's no certainty that a vaccine will be developed. We certainly all hope and pray that a vaccine will be around the corner, but there's certainly no guarantee that's going to happen. And the recognition that our emergency preparedness for a world in which business and international travel provides susceptibility to a variety of illnesses that can be brought to our doors very, very rapidly makes us think about the investment in public health that we should be thinking about for the future. Mental health concerns with COVID-19, the stress of social distancing, the loneliness associated with the social response that's been necessary to reduce transmission of the virus makes Canadians think about the mental health challenges. Certainly in the last round of federal, provincial, territorial negotiations leading to a new health accord, the federal government supported mental health with increased federal investments over and above the Canada Health Transfer. And I think Canadians recognize that dealing with mental health concerns, ensuring that our publicly funded system offers talk-based therapies for mental health diagnoses is, again, high on the list of Canadians for investment. One of the things that's occurred through COVID-19 is a new reliance on virtual care. Canada has been slow to take up virtual care, which is recognized as being more convenient for both clinicians in many cases and for patients certainly. And with the inability of patients to reach their doctors face-to-face through the COVID-19 pandemic, we've become used to using new technology. A report from the Canadian Medical Association in the last 24 hours details that more than 50% of Canadians have used virtual care during the course of the pandemic. The need for us to focus on better data and pan-Canadian data, the recognition of how out-of-date our public health data systems are across the country, and the need for better analytics to understand how viruses are spreading, how healthcare risks are seen across the country, and how we can counter those healthcare risks. We recognize that our analytics are lacking, are stressed with COVID-19, and investment in data and analytics is necessary. You know, the change that's occurred in our hospital sector, resulting in enormous backlogs of surgery, diagnostics, investigations, radiology during the course of the COVID pandemic response, makes us realize again how challenged Canadians are with respect to wait lists for MRIs, for investigations, for surgery. It's recognized that clearing that backlog of surgery is going to take months, if not years, unless further investments are made in access to surgical care. And, you know, this probably is a bigger priority for most Canadians at this time than investments in Pharmacare. The crisis that our long-term care and nursing homes have faced in terms of congregate living for seniors makes us think about the importance of keeping people at home as long as possible, safe from infectious disease in their own homes, receiving home care. And again, the balance between long-term care funding and home care funding makes us think that investments in home care are essential. And finally, Michelle, I'll pass back to you for thinking about how Canadians are regarding the enormous deficits that are developing, not so much from a perspective of healthcare spending currently, but with various levels of support, and how this is going to impact on investments in health in the future.
Thanks, Bob. It's certainly fair to say that when we look at that list, the Canadian healthcare system is undergoing an unprecedented and rapid evolution. So it's a real live question about how much change from a financial, a fiscal, but even a system reform point of view can we manage simultaneously. And that list on the previous slide, you know, those weren't nice to have. That change is underway. It will have to be supported over the next 2 years. And in my mind, politically, how much support will another additional change, when frankly the coffers are bare, can the country really entertain? So if we go ahead to one more slide, we have one more slide, and then we'd be happy to take questions. So what comes next? I think we've touched on some of these, but just wanted to reiterate that the PMPRB reform is a key and missing part of the puzzle federally. So that really has to fall into place for the federal government. And its path is not assured. As I said, still some substantive negotiations going on with respect to those changes. Long-term care is going to dominate the conversation politically for the foreseeable future, as well it should, given what we've seen through the COVID period. It's going to dominate the concerns of many Canadians and therefore the politicians. So again, that policy shift is enormous. The provincial health systems are going to be under enormous financial strain. That's going to have a real impact on what the provinces are asking the federal government for. In fact, heading into negotiations in the pre-COVID period was when the premiers first raised the prospect of a 5.2% increase in the health transfer. So even before COVID, they were signaling to the federal government that this was not their top priority and they had other issues that needed to be tackled. That's only more true, of course, today. We also will see the federal government play a more activist role going forward. You've seen, of course, them collaborate closely with the provinces. That's not likely to change. I think both levels of government understand that they need each other for different reasons. But you will see the federal government more engaged on the health file, and I think you will see them be less deferential. In fact, the recent announcement over the past week of an increased transfer to the provinces came with strings, and the premiers weren't happy about it, but I think that's the sign of things to come. So I think at both levels, the governments will be asking themselves how and when to move Pharmacare forward, given all of the challenges they face and the immediate response that's required from government. But were we to see Pharmacare move forward for the reasons that Bob talked about earlier, I think you should be looking for signals around the Canadian Drug Agency. It is likely to be the first concrete step the federal government can take, but I think it is an open question of when the government will be able to really move that ahead. So with that, thank you very much for participating today. We'd be very happy to take questions, and I think we're going back to Jason.
Michelle, Dr. Bell, thank you so much for this informative and insightful discussion. Clearly some puts and takes arising as a result of the pandemic here. Ladies and gentlemen on the line, it's time for our Q&A. You can ask a question over the phone by dialing 01. Our moderator, Fanny, she'll connect you in. Otherwise, we're taking questions into the queue, and we have a few in there right now that I'll go to while we wait for questions on the line. So, Michelle, I'll direct them to you, and if you want to navigate between Dr. Bell and yourself.
Sure.
The first question was 13% of Canadians not covered by the drug program. Do the speakers have a description of the group of Canadians not covered? Are they homeless, Indigenous, new immigrants, other?
Bob, you probably are in a better position to address that.
Well, you know, that varies, Jason, across the country. You know, the typical Canadian that doesn't have adequate drug coverage might be a new Canadian, for example, who's working in a service industry, part of the gig economy where there's no workplace insurance provided, where they're not in the age group where a seniors program would cover them. They're not living in Ontario if they're under the age of 25, where people up to the age of 25 are covered by public drug plans unless their parents have coverage that extends to them. So there's just a smorgasbord across the country of people who are either uncovered entirely or their coverage is inadequate. And certainly, you know, the stories of taxi cab drivers who have to choose between providing themselves with metformin for their type 2 diabetes or paying rent and putting food on the table for their families. These are true stories. They're not made up, and I think the data suggests that probably about 15% of Canadians are suffering from an inability to pay for necessary pharmaceuticals.
Thank you, Dr. Bell. There's a few here that are financially interrelated. I'll ask one from the queue, and then I'll see if there's any on the line. If the federal government and provincial government agree and go ahead to implement a national or provincial pharmacare plan, how long would we see that it would take to be implemented and effective?
Bob, you and I have talked about that. We see it as a long journey that starts with the formation of the Canadian Drug Agency, but could take as long as a full decade to implement. Do you want to expand on that?
Yeah, well, if we look at the Hoskins Committee advice regarding that to the federal government in a different time before COVID-19 developed, even that report suggested that the approach to getting to a single payer system would probably take 7 or 8 years, and certainly much longer at this point. If you think of the things that are relatively straightforward to do, the two easiest, as I suggested during the course of the discussion, was the formation of a Canadian Drug Agency, and nobody would argue at the provincial level about a federal contribution to pharmaceuticals for rare diseases. Now, if you look at the work that's been done to this date, where nothing has been prepared in this regard, just those two elements alone, the development of an agency incorporating PCPA, incorporating CADA, PMPRB, parts of CIHR, parts of Health Canada, that would be a task in and of itself that we could anticipate taking a year or two. Subsequent to that, the development of an essential meds list, although there are essential meds lists out there, certainly the consultations that will go on around essential meds and the consultations and development of a strategy for rare diseases that would probably include diagnostics, screening tests for newborns, as well as the discussions about how to pay for expensive drugs. These three fairly straightforward first steps, you couldn't imagine them happening in less than 2 or 3 years. Then the question would be, is there progress toward moving more medications under the pan-Canadian Pharmacare approach, or do we simply leave existing drug plans where they are today and have this fill-in-the-gaps approach? Would a Pharmacare plan actually progress towards something that was universal first payer? I think that's a much tougher step than those 3 earlier steps mentioned, and certainly with the economic challenges that Michelle has discussed, a long-term approach, indeed, if it were to happen at all, I think is probably the most likely. Michelle, what do you think about that?
I think that's right, Bob. The other thing I would add to that is if you think about the path and the duration that Pharmacare will follow, we're going to see several federal and provincial elections in that time frame. And how does that change the trajectory for Pharmacare? Because we have not had consensus across all parties in terms of model, but even whether this is a priority the government should be moving towards. And I'm thinking specifically of the Conservative Party reaction to Pharmacare and many of its recommendations. So I don't think we can underestimate what the political dynamics, which inevitably will change over the next decade, will do to the path for Pharmacare.
Thank you both. Fanny, is there anything on the line?
Unfortunately, we don't have any questions at the moment, but just as a quick reminder, if you'd like to queue up a question, please press 01. Thank you.
Okay, we've got a few more here, and if there's no more on the line, we'll just stay through the chat. Would the projected or potential savings of National Pharmacare program provide room for investment into other areas of healthcare, such as backlog of surgeries, investing in long-term care, et cetera?
Well, you know, the complexity, Michelle, if you don't mind, if I start off with this one.
Of course.
The complexity of, there's no question that savings would be accomplished by moving to a Pharmacare system. Certainly just the pan-Canadian pharmaceutical approach of negotiating for all drug coverage for all medications that were provided to Canadians would represent a potential for savings. However, there are other ways to accomplish some of those savings. For example, if workplace employer plans were to have access to PCPA, if CLIO was able to achieve the same savings achieved by the PCPA and purchase their drugs on a national basis, there are savings that could be achieved there. The other thing that's important, of course, is, you know, the estimates of the massive amounts of savings that have been suggested by some proponents would include eliminating the tax advantage associated with employer-provided health benefits. And I don't think that's likely to happen. Canadians like their tax-benefited employment benefits, and even if we were to move to a Pharmacare system, you can imagine other benefits being offered by employment insurance. So I think the potential for savings, you know, although substantial, would be difficult to accomplish. Certainly the opportunity to invest in the surgical backlogs that have occurred is essential. But at the same time, reorganization of surgery perhaps is equally as important. Reorganization of surgical waiting lists, expansion of surgical capacity perhaps wouldn't require the amount of money that is immediately thought of when looking at the surgical backlog. So the surgical backlog, I think, is going to be invested in immediately without waiting for Pharmacare to provide savings.
Thanks, Dr. Bell. We've got 3 minutes remaining. I'll ask this last one here, and I think we'll call it at that. Given the mounting fiscal challenges for the feds and the provincial governments, how much flexibility will there actually be to invest in Pharmacare initiatives? Also, is there no questions that the Fed should fund the health transfers at a higher level, but can they deliver on the 5% plus given the fiscal situation?
Well, certainly that would be the provincial view, is that they should deliver on that 5.2% increase. And in fact, it would not surprise me if that number goes up. That 5.2, of course, was pre-COVID. And so I expect the premiers will be asking for an increase over and above that figure. So, yes, I think there will be a lot of political pressure on the federal government to increase the transfer. And I think they've shown a willingness to do that through the pandemic period. But what provinces will not be happy about and not accustomed to is, I think the federal government, certainly under the Liberals historically, they tend to tie increased funding to priorities. And I don't see blank checks coming from Ottawa to the provinces. I think it will be tied to priorities that they attempt to negotiate with the provincial governments. But as we've seen over the past month, it won't be a blank check sent to the provincial capitals. Bob, I don't know if you want the last word on that.
Well, we remember the experience during the last health accord discussions where, the prior 6% escalation in the Canada Health transfers suddenly dropped to nominal GDP or 3%, and funding for home care and for mental health was added to that as a bit of a sweetener for the provinces and territories. And of course, the provinces protested. They wanted money through the transfer rather than targeted money for mental health and for home care. And they wanted the escalator to remain maximized. And of course, the federal government said, well, take it or leave it. Sign up for that or don't sign up for that. And as I mentioned earlier, within a matter of months, all provinces were on board. So I think the federal government, as Michelle said, will want to tie increased expenditures to a targeted approach, and I think the provinces will have a hard time turning down the money.
Michelle, Dr. Bell, thank you so much for your participation and your insights today. Truly a topical session. Lots of great insights, lots of great interest from the Q&A here. We've done over 15 minutes of it. Our time is wrapping up. To those on the line, we hope you found this information valuable. As always, it's been an honor for us to be able to deliver this content to you this year in a virtual format. And as we mentioned at the onset, we are recording this webinar. It will be available online in about a week's time through our TELUS Health Benefit Hub. Please subscribe, check out this webinar or past webinars if you haven't. And as a reminder, again, there's a survey. It'll take about 3 minutes. You should receive it in about a moment when you log off. So please help us get better at this for future. And for CE credits, expect to hear back from us in a couple weeks' time. And to our sponsors and supporters, thank you for helping make this series possible. And Dr. Bell and Michelle, we'd like to thank you for your participation, and to those in the audience, we hope you enjoyed today's presentation as well as those we've shared previously. It's been our pleasure to bring this to you. Thank you again to our speakers today, but also to our marketing team behind the scenes who helped us pull this off without a hitch, and to you, the audience, who've shown up in incredible numbers over the last 5 weeks for really taking the time to join us. So thanks very much. It's been our honor to host you. Have a wonderful afternoon. Stay safe, and hope to see you next year in person. Take care.
Thanks, Jason.